So I'll start off with a talk which I'm entitled Similarities of the AV Valves and the Fundamental Differences of the Ventricles, although it should be similarities and fundamental differences of both. You know, it was always good to go back to some embryology to start with and ask yourself the question, how does an unseptated and valveless tube turn into this complex four-chambered organ with chambers, arterial trunks, and separated by one-way valves? And when you go back to the embryology, of course, you realize that the right ventricle starts out as a separate organ from separate tissue. The third week of gestation, the lumen forms in the primary endocardium of the heart that, when developed by myocardial cells in the primary cardiac crescent, becomes converted into the initially valveless and inverted Y-shaped tube that initiates the circulation. In time, this primordium will become the larger part of the left ventricle and part of the atrial chambers, not the right ventricle. The future right ventricle and the outflow tract, along with much smaller parts of the LV and the atria, take origin from a spatially distinct area known as the secondary heart field. So it is interesting, isn't it? It doesn't tell us much how to handle it, but we are dealing with a different organ, essentially. And the cells migrate at a later stage from this area to become integrated within the arterial and venous poles of the developing looped heart tube. And you can see here, this is the left ventricle in this early stage, and this is the right ventricle beginning to bolt itself on as it's moved through the mesenchyme. So, very interesting thought. The valves themselves, as early as 6 weeks in utero, the atrio-ventricular cushions fuse and divide the AV canal into the primordium of the right and left atrio-ventricular junctions. So you have these outpouchings of cushions. When I come back at the lunchtime session on the mitral, I'm going to refer to this because I think an awful lot of the mitral valve disease we treat is congenital and not acquired, and it comes from the embryology. So the morphology of the valve, the tricuspid is oval in shape, and you can see it here, more of an oval, whereas the mitral valve, even its compressed and collapsed excised heart, has more of a D shape. It's multiplanar, even more so than the mitral. The mitral has the saddle shape. The tricuspid has a saddle shape as well, as you'll see, but it is much more multiplanar, which is why there's a new interest in tricuspid valve rings going on at the moment. How do you address getting these leaflets to oppose in the appropriate way? Its diameter is around 4 plus or minus 0.7 square centimeters. Its annular area is 10, which is, of course, significantly greater than the valve orifice area. And this comes up in study after study. So orifice area is hugely different to annular area. Both have leaflets attached by cords to papillary muscles to the ventricular wall. And the top one is the mitral valve, the bottom is the tricuspid valve. And you'll see as I go on in my talk that these attachments, and their attachments to the papillary muscles, is actually quite important. The anterior leaflet is the most mobile of the tricuspid valve. You can just about see it in the background here. This would be the anterior leaflet. Here would be the outflow tract. The tendon of Tadara will be running around that air bubble into the blood. The septal leaflet's here, and the inferior or posterior leaflet, whichever you want to call it, is here. And of course the conduction tissue is here, and the coronary sinus down there. So the anterior leaflet is the most mobile and semicircular, and it lies adjacent to the right ventricular anterior free wall. And that bit of anatomy, of course, is profoundly important, and we use that in our way we approach. Oh, thank you very much. That's lovely. Bless you. Thanks. Oh. That one? Yeah. Oh, great. Thank you very much. Yeah. The septal leaflet is the least mobile, it's semi-oval, and it's adjacent to the inferior anterior right ventricular free wall. And most of the approaches to tricuspid valve reconstruction repair make use of the fact that the septal leaflet is often the most least mobile. And of course, in the Epsteins, that is at an extreme, so that's when you have to introduce new leaflet tissue. The posterior or inferior leaflet is the smallest and very variable in shape, adjacent to the septum, etc. What I want to show you as we go on, this is much more complex than you think in terms of leaflet anatomy. This is just to get your bearings. Here's the aortic root, anterior leaflet, inferior leaflet. You see with multiple parts to the leaflet, septal leaflet, right ventricular free wall, and the septum. This lies between two low-pressure chambers, so the actual pressure function on the valve is very different, and the three leaflets as are listed there. Go back into the tricuspid valve shape, this multi-three-dimensional shape. And you can see this is the height relative to the neutral plane of the tricuspid valve. The highest point's at the anteroseptal commissure, the lowest point is at the posterior septal commissure, and the anteroposterior commissure is in the middle plane. So the anteroposterior, if you just get your bearings, anteroposterior, anteroinferior, the sort of extreme right-hand corner, as you look at it from the surgeon's eye, is in the septal plane. And these are things that we don't tend to think about. Does it matter? We can ask ourselves as the day goes on, but actually matter for the normal functioning of the tricuspid valve. And here is just the functioning of our tricuspid valve. Here is the so-called anterior leaflet, the inferior or posterior down here, septal here. This is screwed, I put this in deliberate. This is a pacing lead across the tricuspid valve, which I would just remind you all, it's the commonest cause of tricuspid regurgitation of any of them, the placement of a pacing unit. This is just to show you a bit of the subvalvular apparatus. Here are the leaflets and here are the chordae. And I'm going to show you more detail of the anatomy inside the heart in a moment, actually showing the arrangements of the cords. So when we look at length and so forth, the anterior and septal leaflet length is approximately the same length. The posterior leaflet was the shortest. The anterior leaflet was the tallest and widest and has the largest surface area. So it mirrors the anterior leaflet of the mitral valve in that way. The posterior leaflet was wider than the septal leaflet with the smallest surface area. And of course, being cognizant of these facts has another practical application, and that is if you want to translocate parts of the tricuspid valve to the mitral valve in endocarditis. You can just think about this when you're choosing which bit to take. So here's a comparison of the inside of the inflow tract. Here is the mitral valve. See much better developed papillary muscle and cords. The cords and papillary muscles of the right ventricle are very, very much more diffuse and actually difficult to map. This is again the left ventricle, just to show you this very definite and clear-cut inflow path of the left ventricular tract. The red dots mark the infundibular outflow tract on the right side of the heart. So if we look at the, this is actually a tricuspid valve of an ox that I dissected out, doctored with Photoshop, and this is a drawing from you-know-who, showing the various aspects of these leaflets. The posterior leaflet, it's a depth and width for each one. And in length, B equals C, which is greater than A. So anterior and septal, same length, both longer than posterior. In width, 2 is greater than 1 is greater than 3. And in surface area, the anterior is greater than the posterior, is greater than the septal. So just a little orientation in terms of size. Now, what you find in the tricuspid valve is you find these accessory leaflets, which may be spurious or true. The accessory leaflet, one is shown here at this commissure, has cords from 2 papillary muscle heads. So if you have an accessory leaflet receiving cords from 2 papillary muscle heads, it's called a true accessory leaflet. And you can see why here. It looks like a true accessory leaflet. A spurious accessory leaflet receives cords from 1 papillary muscle only. So they tend to be unsupported on one side. Now, we talk about it as the tricuspid valve, but a very large study, which I've coalesced 2 or 3 studies which come out with the same results, you can have everything from 2 to 7 leaflets of the tricuspid valve. Of course, the commonest are 3 or 4, but 5th, with the kind of accessory leaflet I was showing you, particularly in the inferior or posterior position, is not that uncommon. So 3 to 5 leaflets of the tricuspid valve is actually the commonest configuration. A little bit of geomorphology here for you. Referencing, here is the aortic valve at the anteroseptal angle. And this just shows you how the leaflets tend to fall open and why you have this restricted orifice area in the tricuspid valve relative to the actual annular diameter. And this just shows you, I want to make the point also, one of the differences when people talk about annular diameter between echocardiographic measurements and intrasurgical measurements, as nicely shown by Gilles Dreyfus, is that we're measuring different things. The echo measures the anteroposterior plane. In surgery, we go from the, this commissure ought to be a bit lower, the anteroseptal commissure, out to the anteroposterior inferior commissure. That's why you have the difference between 4 and 7 centimeters as the oft-quoted difference in size. Just to give you a little more anatomy of the relationship of the 3, of course, in the middle here is the common fibrous central portion of the fibrous heart, which links the 3 valves together. And you can see the relationship of the anterior and septal leaflet of the tricuspid valve to the aortic outflow tract. And you will see that this pushes in the tensioned heart. So if you repair your tricuspid valve with the heart tense and beating, which is what I tend to do, you will see that, and it helps you configure your suture placement and so forth. And then the septal relationship of the AV canal of the right and left AV valves. And you can see it here. Now, the point of this slide I want to make is if you look at the relationship of the tricuspid valve to the free wall of the right ventricle, the anterior and part of the posterior or inferior leaflets are the ones that register next to the free ventricular wall. And as you know, unlike the mitral valve, the vast majority of tricuspid regurgitation that presents is actually through functional regurgitation. In other words, distorted, distended right ventricle, in usually response to left-sided chronic problems, although there are other issues that will be discussed today, I'm sure. So that tends to pull the leaflets apart, antero-posterior, from the septal leaflet, giving rise to this increased orifice. And again, as I say, if you go around the trade stands and the big meetings, you will see now this trickle of new styles of tricuspid rings coming out. People are beginning to think about this anatomy. Now, quickly, in the last 5-10 minutes, I will talk about the right ventricle and its structure to function. And the two ventricles differ in many ways which reflect their functional status. Well, that's a bit of a tautology, but you know what I mean. And here is the left ventricle. And this relationship between left ventricular wall through the septum to the right ventricle is very important, particularly in acute heart failure, which we'll talk about now. The right ventricle has much coarser trabeculae, which allows easier distension. Trabeculae are in the heart to allow expansion, rather like the pleats in a lady's skirt. It allows the chamber to expand. The right ventricle has a moderator band. It reflects its thinner and freer right ventricular free wall. It has a lack of fibrous continuity between the inlet and the outlet valves. On the left side, of course, you have the aortomitral curtain, but on the right side you don't. The pulmonary valve sits in a free-standing muscular tube, therefore, and this is, of course, the infundibulum. There is a structure called the crista supraventricularis, which courses between the pulmonary valve and the tricuspid valve, aiding free wall contraction towards the septum. So the moderator band and the crista supraventricularis are muscular structures to help support this relatively thin right ventricular free wall. What's happening now? Can I get rid of that? Thank you very much. The right ventricle is therefore thinner, and it reflects its lower operating pressures. It is a complicated geometry, however, and here's a computer-generated image of the right ventricle wrapped around the left ventricle, and here it is in these dissections that Buckberg and others like to show us. The comparison between the structures here is more detailed with figures to it. End diastolic volume, as you can see, is bigger in the right ventricle. The mass is smaller than the left ventricle. We've talked about structure and shape. Thickness of the ventricular wall, much less than the left side. Ventricular pressures generated, of course, as we know, a whole order of magnitude different. Ejection fractions similar, but not the same. And those of you who have tried to do experimental models of separating the right and left ventricle know that the bronchial circulation commits 10% of the output to the left side. So there is actually a higher, to the right, so there's a higher output on the left. Compliance is different. The filling profiles are different. And if you look at the arterial profile, the dicrotic notch that you see on the left side is lost on the right side. The pulmonary vascular resistance as opposed to systemic vascular resistance, you know, and so on. So this is a point that I want to really make, though. The resistance to ischemia seems to be greater on the right side than the left side. So this incidence of functional tricuspid regurgitation as opposed to ischemic disease, which we talk about such a lot on the left side, ought to be present on the right, and indeed is, with right ventricular, right coronary artery disease, especially in the right dominant system. But it's not seen as often as you might think, and it's something to do with this ischemia. So remember, we go back, different cell type, different embryological origin, all parts of the heart not yet fully understood, and probably contributing to this. Now, in terms of adaptation to disease state, the right ventricle is much better and more quickly adapts to volume change. You expect it to do this through sinus of Valsalva maneuvers and just volume overload. The left side is much better adapted to pressure change. The right ventricle is divided into three chambers. There is the inflow, which is basically the tricuspid valve and the cords and the papillary muscles. The body, which is really below the moderator band, which is very variable in the human heart as opposed to other animal hearts, and is down to the apex. And the outflow tract is the part going out through the pulmonary valve and the infundibulum. Here's the septomarginal ventricularis that I mentioned, which links down to the moderator band down here. This is just to show this. Here is the moderator band. Here is the ventricular infundibular fold, separating the pulmonary valve from the tricuspid valve, and the septomarginal trabeculum is down here. And this splits into two arms. So these are all support mechanisms for this easily distendable right ventricle. The left ventricle, as you can see, a totally different structure in terms of mass, chamber size, and geometry. However, you cannot consider the left and right ventricles separately. The right ventricle has helical fibers like the left. The left fibers are arranged in a helical continuum from subendocardium to subepicardium. But it lacks a middle layer, which the left ventricle has. The left ventricle has this middle layer of circumferential constriction fibers. And this is what gives rise to the argument between Buchberg on the one extreme and Bob Anderson on the other about this idea of this helical arrangement of fibers, which starts at the base and ends up at the papillary muscle, and you can open it all out. Actually, you can't. You can make the heart do that when you boil it and destroy all the connections, but there are these oblique fibers which are progressively arranged, particularly through the middle myocardium, which contribute to this contractile kick of the left ventricle. The septum is very much considered part of the left ventricle, not the right ventricle, although there are important interactions I'll mention in a moment. The oblique fibers shorten the ventricle and torsion and rotate the LV apex, giving this wringing out of the towel effect that you need to go from 12 to 15% that each myocyte can contract to a 70 or 80% ejection fraction. It is not all myocyte shortening. It's this wringing out of the towel through torsion. Hence the discussion of cardiac twist in the failing heart, where it unfurls. Right ventricular contraction is much more peristaltic-like. It tends to start at the base and then rolls up through the infundibulum. And this is due to the obliquity of the fibers and the lack of this inner layer. The infundibular fibers are circumferential. So it goes almost like small bowel peristalsis to colonic sequestration. You see what good a general surgical training gives you? I even remember that. However, if we go back to the right ventricular physiology, low hydraulic impedance of the pulmonary circuit gives the right ventricle a unique physiology. The muscle fibers may be different from the left, and when you look at fiber type, there's faster twitch velocity and they're more efficient, which gives them this rapidity of response to volume overload. The right ventricle output approximates that of the left with a much lower myocardial energy cost. It works more efficiently, and right ventricular ejection continues in the presence of right ventricular pressure decline. So it has a different physiology. If we look at flow volume loops, the whole map of the left ventricle from the right is completely different. If we start to think about normal physiology, the impact of breathing, inspiration gives a significant increase in venous return and right ventricular preload and reduces right ventricular afterload. So you get this increase in right ventricular filling. The decrease in right ventricular preload on expiration is added to increased afterload, which you see in increased airway pressure. So if you put pressure monitors in the heart with the closed pericardium, and it's very important to do it with the closed pericardium, you can measure these physiological differences just as you're sitting there at rest now. Any increase in right ventricular impedance, pulmonary, positive pressure ventilation, cardiopulmonary bypass, will cause a decrease in contractile performance and cardiac output, measurably regularly by this amount. So if you've got a failing left ventricle and you have someone on a ventilator and someone on a bypass machine, you will see that they're working at a negative index of performance in these patients with right-sided problems. Both ventricles exist within the same visceral space. So the presence of the pericardium is important. And yet all studies that have looked at the impact of closing the pericardium after surgery have been rather negative in positive outcome, if you follow me. But there must be something in it. And we also know that once the pericardium's opened at surgery, closed or not, the right ventricle never works the same afterwards. And as I said, there are common fibers in the superficial layers of the septum. So normal right ventricular contraction relies upon normal left ventricular contraction. Ralph Damiano, when he was a junior professor, did some very nice work decoupling right and left ventricular contraction by bundle ablation. And he showed if the right ventricular contracted with an inert left ventricle, there was no discernible increase in left ventricular intracavitary pressure. So the right ventricle was doing very little. However, converse was true. If the left ventricle contracted with inert right ventricle, there was up to 30% contractile function in the right ventricle. So the septal contraction is driving a significant amount of left ventricular function. Hoffman then went on and did some further interesting studies where he excised the right ventricular free wall and replaced it with a Gore-Tex patch. And what was interesting, just if you put the right size patch in, there was no impact on right ventricular function. If the patch got bigger, mirroring right ventricular dilatation, right ventricular function and efficiency fell off extremely rapidly. So volume has a very important part on the right ventricular function. So I'm going to stop there and just summarize quickly with a few points. The tricuspid and mitral valve have similar components, but as you can see, their functional relationship is very different. Most tricuspid malfunction is functional. The left ventricular papillary muscles are well developed, the right are not. The right ventricle is volume and impedance sensitive. The left ventricle is pressure and afterload dependent. The right ventricle is much more difficult to assess, we all know that. And left ventricular contraction can develop up to 30% of right ventricular output. And the right ventricle makes almost no contribution to left ventricular output in terms of actually driving the left ventricle. Of course, its output and its passage of blood through to the left side is essential. And Harvey was the first to describe that in 1650. However, in terms of left ventricular function itself, it has little impact. So I'm going to stop there and thank you for your attention. And hopefully many of those points will come up later in the day.